Good afternoon. Welcome to today's session on the present and future of cytomegalovirus viral load monitoring in transplant patients. My name is Scott Hauenstein. I am the Director of Scientific Affairs at Bio-Rad Laboratories, working in our clinical diagnostics group. Unfortunately, Dr. Khalil cannot join us today, so we will just go ahead without, he's walking in right now. Just a couple of housekeeping items. I would remind you to silence your cell phones and that questions can be submitted for the speakers through the online audience through the chat function, and we will save all the questions from the in-person audience till the end for our Q&A panel with our three speakers. I'm joined today by Dr. Khalil. He's from the University of Nebraska Medical Center, Division of Infectious Diseases. He also serves as a director for transplant infectious diseases. Dr. Khalil, would you like to say a few words on this topic before we introduce our speakers? I think they're on.
Yeah.
Yep.
Thanks so much, Scott. Appreciate it. Just a quick introduction is that probably everyone sitting in the audience knows, as I know, that the number one opportunistic infection that we're seeing in our organ transplant patients, it is cytomegalovirus. It is the most prevalent infection that we have post-transplant, and I'm really excited about this symposium because we have so much to learn, so much to really improve in terms of diagnostics and treatments for cytomegalovirus infections. I think that this is something quite needed, and I'm really looking forward for this session.
Great, thank you. Our first speaker is Dr. Giovanni Travi, Medical Director at Niguarda Hospital in Milan, Italy. She is a specialist in infectious diseases with a focus on infections in immunocompromised patients, including transplant recipients. She serves as a clinician and infectious disease consultant, managing infections in hematology oncology and solid organ transplant patients. Dr. Travi will present on the importance of CMV viral load measurement accuracy in guiding clinical decisions in the era of new therapeutic options. Please welcome Dr. Travi.
Thank you. So we all know that despite several advantages in management of CMV in the last years, CMV still causes huge morbidity and also mortality in transplant population. And total amount of morbidity caused by the indirect effects of CMV may exceed that currently attributed to end organ disease. As the CMV induces a long-term inflammatory bias, it can contribute to different medical conditions without sometimes manifestation its presence. And when we talk about CMV, we are not just talking about transplant patients, so not just HCTs or solid organ transplant patients, but we talk also of patients living with HIV, and think also about recent data on the effect of CMV in not really immunosuppressed patients, as those staying in the ICUs. So we all know that CMV quantification is the lab method of choice for rapid diagnosis of CMV infection. And we may use our assays. Our assays may be calibrated using the WHO International Reference Standard. We may report our viral loads in unit per ml. But the problem is that even if viral loads are reported in unit per ml, the viral load values are not similar among different assays, and we are not able to interpret these assays, these results interchangeably during clinical care. So each transplant center has its specific thresholds depending on the assay that it currently uses. And CMV quantification for this reason should be performed using the same assay. And of course, in reporting viral loads, the name of the assay should be specified. We know that there's a difference between whole blood and plasma, and when we monitor CMV, we should use only one sample type. But as a transplant physician, we see many solid organ, especially in solid organ transplant, who are discharged not far from transplant, maybe sometimes a few weeks after transplant. Think about liver and kidney recipients. And several weeks after transplant, they may go back home. And sometimes in my center happens that they're not able to come back to transplant center as frequently as we want. And so they send us back, they send us the results of blood tests from local labs. And it's not, unfortunately, it's very frequent that in those results, we do not know the assay that it has been used. Results are in copies per ml. We don't know the units. We don't know any conversion factor. And sometimes we do not even know if CMV has been quantified by whole blood or plasma. So we are not able to compare those results to our assay. It's pretty obvious that we need an accurate assay for rapid diagnosis of CMV infection, as we do not want to develop those direct and indirect effects related to transplant, related to CMV reactivation in transplant. And we need accurate assay also to decide our standard threshold. We know that higher viral loads correlates with symptomatic and more severe disease, and we know that we need accurate assay in order to see if we have a viral decline during therapy, and to immediately and promptly identify those refractory CMV infections. And we are more aware right now of indirect effects of CMV in or solid organ transplant, as with preemptive and prophylaxis strategies, now we see less CMV disease. This is an old study, but I think it's a pretty complete list of what CMV can cause in solid organ transplants. And you see that at the end, it may cause acute rejection. It may be related to a graft loss, as it can be involved in chronic allograft nephropathy and hepatic artery thrombosis, allograft vasculopathy in heart transplant recipients, bronchiolitis, and we know that it can be also related to bacterial and fungal and other viral infection as EBV and the risk of PTLD after transplant. And last but not least, of course, these all indirect effects may induce also a higher mortality. But when we have to look and check CMV in our patients, and here an example in HCT is patients with CMV reactivation before transplant had a 5-fold risk of post-transplant reactivation. And there's a lot of evidence on the relation of CMV to higher mortality in HCTs. So probably we have to check and quantify CMV also before transplant, at least in HCT and in HCT. Fortunately, with the new prophylaxis drug that we are using in HCT setting, and hopefully also in my country very soon in kidney transplant patients, we have an effective drug, and we have less side effects than the standard therapies, and we can use a prophylaxis in HCTs very soon, immediately after transplant. But we know that even during prophylaxis, we need to quantify CMV, as letermovir rarely, very rarely can fail, and the patient can develop a resistance, or we may face with a CMV abortive CMV, and so the copies we see there are not really expression of CMV replication, but just a defect of the drug. So an accurate assay is really crucial to determine when we have to stop letermovir or not. And moreover, when we stop prophylaxis, as with other drugs, viral loads might rise upon discontinuation, and if used, of course, as secondary treatment. So again, CMV has to monitor very closely. And Here are some cutoffs proposed to treat CMV from different centers. We see that the patient population in HCTs are divided into high-risk and low-risk patients. And you see that proposed cutoffs are pretty low in this population, as CMV has is related to high mortality rate. So again, to monitor this patient right now, we have to use the same assay because we do not have reproducible results between different assays, and again, accurate assay too. Going to solid organ transplant, I just want to show this recent data on any viral prophylaxis or preemptive treatment. As we all know that guidelines suggest in high-risk patients, so donor-positive, recipient-negative patients, prophylaxis strategies to reduce the risk of CMV primary infection immediately after transplant. But some data demonstrate that CMV disease may be more frequent late after when we stop prophylaxis. So a preemptive treatment has been proposed for liver patients and some kidney patients at high risk of primary infection, so R minus the recipient negative and donor positive, as they may develop immune response and control better in CMV infection and to reduce the risk of CMV disease. In this case, we have absolutely to follow strictly the patient and to start very promptly CMV therapy if the patient reactivates, and we right now are not able to do and to use this approach other than in those patients who live closely to a transplant center and who check the blood test from our transplant center, so using the same assay. But CMV is a huge problem also late after transplant. Here, just to show you that also in kidney patients, when we follow also patients several years after transplant, patient may reactivate. CMV may develop an asymptomatic viremia in 30% of cases, and we are talking about a median follow-up of 80 months. And 2.9% of these patients may develop a CMV disease with a risk of graft loss and chronic rejection. And these patients are those who really need, who sometimes come back to transplant center less frequently than the others. So we may miss CMV reactivation if we do not ask them to check CMV in other labs closer to their houses, and having a reproducible result is really needed. We are using, or at least some centers as mine are using CMV immunoassay, just to say that, of course, even if we use assays, we cannot miss, and we have still to use CMV quantification and CMV PCR. Maybe weekly immediately after transplant, then less frequently. And going to the new definitions of refractory and resistant disease, again, as refractory CMV infection is defined as CMV viremia that increases more than 1 log increase in CMV DNA levels. We have to use the same blood compartment from the peak viral load as measured in the same lab and or with the same assay. So we need to strictly follow the patient and know very well which assays are used to check quantify our CMV. Having a CMV-resistant infection affects not just not just the patient and our choice of therapy, but is related in solid organ transplant in this case to rejection for kidney transplant. And in the study, they show that people 1 year survival following CMV diagnosis of ganciclovir-resistant CMV is lower in those with resistant CMV. and mortality rate is lower at 3 and 12 months. Fortunately, now we have new drugs. We all know the results from SOLTI studies and the other studies on maribavir. We know that maribavir performed better than standard of care, but we know that higher rates of CMV recurrence on therapy were observed in the maribavir arm, and up to 22% of initial responders developed recurrent viremia after stopping maribavir. So again, when a patient is on maribavir, that's very useful. It's an oral drug. We need to strictly follow the patient and absolutely with the same assay. So just to end my presentation, standardized results and reproducible results of CMV viremia are needed to reduce CMV morbidity and mortality in immunosuppressed subjects, as CMV is linked to so many complications in different populations, not just the immunosuppressed one, that we want to lower those complications and treat very promptly CMV reactivation to avoid especially the indirect effects of CMV. Thank you very much for your attention.
Thank you. Our next speaker is Professor Vincent Thibault, who serves as the head of the virology department at Rennes University Hospital. He is also a professor at the University of Rennes and affiliated with several prominent research institutions, including INSERM and AIRSET. His research encompasses a wide range of topics, including hepatitis B and C, respiratory viruses, and emerging infectious diseases. Professor Thibault will present the results of a study that asks the question whether CMV viral load reported in international units is adequate to compare results across laboratories.
Thank you for this kind introduction. Good afternoon to everyone. And first of all, I would like to thank Bio-Rad for putting up this symposium and you for attending it. So after this very interesting talk given by Dr. Travi, I will more focus on the analytical aspect of CMV viral load monitoring. And I will focus my talk mostly on a multicentric study that we have performed recently in different labs in France and abroad. So this is my disclosures. So as you've heard just before, I think it's interesting to look at the risk of developing an organ disease in transplanted patients. And we know that depending on the status, the serological status of both the recipient and the donor, the risk is different. The higher risk being to have a primary infection or a reinfection or reactivation. And depending on the situation, the risk is more or less important. And the determination of the serological profile of the donor and the recipient is quite important. That's another topic that would be interesting to focus on. Of course, if you want to reduce the risk, there are two different strategies. The first one, as Dr. Travi said, is antiviral therapy by prophylaxis. Unfortunately, sometimes you delay the clinical symptoms, but you may have also risk of a late onset disease. The other option is to have a preemptive therapy that relies on monitoring the CMV viral load, then start antiviral therapy as soon as you detect CMV viral load in your patient. Of course, we can have other tools. The first one being the CMV immune monitoring. It might be useful, but still there is no real consensus about how to use this marker. Sometimes it's interesting because it may help you to stop the antiviral therapy, but again, it's your own experience that may help you to handle this issue. Then you can also use TTV viral load monitoring. I think it's an interesting marker. It has been shown in different situations that if you have a very high TTV viral load, it means that you are too much immunosuppressed. But if you have low TTV viral load monitoring, TTV viral load, that means that you may encounter rejection. So on this slide, you clearly see that there is a need of CMV viral monitoring, but what are we doing when we follow CMV viral load? We have to go back a little bit on the physiopathology of cytomegalovirus infections. And we know that when you get primary infection, you have infection of epithelial cells, endothelial cells, and then the virus will propagate into the body, infect monocytes, and eventually you will have a reservoir within hematopoietic progenitor cells, CD34 positive. Upon differentiation or reactivation, you may have CMV produced from monocyte, then differentiating into macrophages, dendritic cells. These cells may migrate into different tissues and cause organ disease, and which is very preoccupying. Of course, what we can do is to measure the CMV viral load. But you know that we are all working with different matrices. Some of us use whole blood, some others use plasma. We also may detect CMV in BAL, urine, biopsies, etc. And we don't really know what is CMV DNA into these different matrices. We know that there are probably a lot of fragmented DNA. We know that there are some variants as well, and also viral exosomes. But so what are we clearly measuring when we monitor CMV DNA? So clearly we need something that is reproducible. And unfortunately, you see that if you look at EQA program, the external quality assessment programs, and I've taken the results from the QCMD 2023, and I've only put on this graph the result from the commercially available methods that are given in international unit per mil. So you see that this panel is made of either supernatant cell culture supernatant with the strain AD169, and it is also composed of CMV clinical specimens, and two of them being educational with low viral load. And you clearly see on this graph that there is a consensus value, but there is a very high dispersion of values apart from this consensus value. And if we concentrate on one specific clinical specimen, like here, you see that in one lab, you may have a result of 2 log international unit per mil, and with the same clinical specimen, you would get 4.3 logs. So in other words, 95 international unit per mil is equivalent to 22,000 international unit per mil. So you clearly see that it's very difficult to compare results from different laboratories, and this is real data from EQA. And I think it was very interesting during this meeting to listen to the different new recommendations that just came out this week and the week before regarding the follow-up of transplanted patients, both in solid organ transplant and hematopoietic stem cell transplant. And I don't think they recommend any more clinical threshold, because basically what you have to follow definitely is the kinetics of the CMV viral load rather than an absolute value at one point. So if we now consider this aspect, we decided to start a study with the different objectives. The first one was to compare the real-life CMV viral loads quantified by several virology labs that I will show, both on clinical plasma specimens, on the WHO international standards, and also on commercially available standards. The second objective was to evaluate the possibility to standardize the results across laboratories using standards. And finally, unfortunately, I think we failed at that, we wanted to identify the reason for the lack of commutability between labs. So we did perform this study. I can tell you it was way before the Gulf of Mexico was renamed Gulf of America. So you see that almost most centers were localized in France. These centers were not chosen by chance. It's only because they are nice colleagues to work with, first, and second, because they were working with different platforms, on different platforms. And we also had this lab at Bio-Rad facilities. So how did we do that? So we first identified a little bit more than 100 clinical plasma specimens with various viral loads, and we selected 60 of them to cover the range of quantifications from 2 to 6 logs. And we were very careful at selecting negative plasma pools because we did not want them to interfere with our results. And we diluted and aliquoted 7 sets. It was prepared by a private company, Specimens, in Clermont-Ferrand in France. And we selected 30 positives of these clinical specimens and 6 negative specimens plus 2 water-containing tubes. Of course, we included in this panel the WHO standard, the EDX standard, which is a commercially available standard, and 2 quality control. Everything was sent blinded to the 7 labs, and at the end we had 92 samples that were duplicates of 30 positive specimens, 8 negative specimens, and duplicates of the WHO standard, EDX standard, and the quality control. What we asked to the participating laboratory was to give out the results in international unit per mil, but we also collected all the CTs, and that was useful to recalculate a calibration curve according to the CT after unblinding the results. So this table is quite complicated, but I think it's a very important table, and I will go through this. You see that all laboratories were working with different techniques. Some of them were integrated, like the Elitech Ingenious system, the Abbott Alinity, the Roche Cobas system. And some of them were working with an extraction process and then an amplification system, which was different. Something we have to look at very carefully is the starting volume of the sample. You see that you have mostly 200 microliters, but we do have also 500 microliters for the Abbott Alinity. Then you look at the elution volume and the concentration factor. This concentration factor is calculated by dividing the starting volume by the elution volume. And you can even calculate the input sample volume equivalent, the SVE. It's quite interesting because you see that there is quite heterogeneity in this ISVE, with the highest ISVE taking into account the starting volume, the template volume, and the elution volumes of 202 for the Abbott Alinity. But what is probably the most interesting part of the slide is this one. You observe that all techniques are working on different target gene. So that might be a first reason for heterogeneity. And the second one, which is not a little one, is the size of the amplicons. And you see that, for instance, if you use an Altona techniques, the amplicon size is 74 base pair. And if you work with bioMérieux, for instance, you work with an amplicon size of 283. You will see that's a very important issue. Unfortunately, we were not able to get the amplicon size of the Roche system. I don't think this is scientifically responsible not to communicate about this size of amplicons. And I clearly encourage manufacturers to communicate about this information. So you clearly see that there was an heterogeneity in the extraction processes, the amplification, and the automation. So now if we look at the results, the overall results, you clearly see that this is each member of the panel, and you clearly see that the dispersion of the value was quite important. Indeed, if you look at this graph here, you see that most of the time the dispersion of the value was much higher than 0.5 international unit per mil, log international unit per mil, which is what is considered a clinically significant threshold. There were some good points. The good points is that there was a very good reproducibility between duplicates. I'm not showing you that, but it was very impressive. There were no false positive, and we could expect some false positive because we had very high viral load with undetectable viral load. And the linearity, as you can see here, was very good. Unfortunately, as expected, we had a very large distribution of the values per sample. Then we look at how were the techniques well standardized against the international standards. And I was very surprised to observe that this is the expected value coming from the WHO or the EDX standard. And you see that except for a couple of techniques, most of the techniques were not well aligned against these international standards. So I think we should try to have a better adjustment against this international unit per mil standard. If you look a little bit differently, you observe that the dispersion of the value, dispersion against the expected value, was different for the WHO standard and the EDX standard. One explanation might be that the number of passages of the cell culture supernatant was different for the WHO standard and EDX standard, but we have not demonstrated that. And you may clearly notice that the integrated techniques, Alinity and COBAS, performed quite well, and they were well aligned against the WHO standard, which was not the case for the others. So now we look at what was the dispersion of value according to the specimen or the standard. Just remind you that the specimens are clinical specimens and the standard are cell culture supernatant. And you clearly see, as we don't have a standard, gold standard, what we have done, we calculated the difference to the mean being the result obtained by all the techniques. That's the only way we could do it. And you see that depending on the techniques, we had different quantification. The difference was different if it was specimen and standard. That was, you see that the specimens were lower for the Arctus, for instance, but it was the opposite for the Roche Altona, for instance, or the Ingenious Altona. So basically, this difference clearly reflects the heterogeneity of the platforms, and I don't really have any clues to show you why there is this difference, but it was, for some of them, it was statistically significant. And then we looked a little bit at the dispersion according to the clinical specimen or the standards, and you clearly see that there is a much more homogeneous result on standard compared to what we see on specimen. So basically that means that probably the standards are much more homogeneous materials compared to clinical specimen. And then, as I told you, we try to take the CTs obtained on the WHO standard or the EDX standard, and with this CT, we perform a recalibration of all the assays just to see whether we could reduce a little bit the dispersion. And you see on this graph here that you see that this is the original value. This is after recalibration against the WHO and after recalibration against the EDX. So you clearly see that you reduce the viral load that we obtain for all techniques. You reduce a little bit the dispersion, but again, you are well over 0.5 log international unit per mil for many samples. So it doesn't seem to be the right solution to do that. So overall, what I can say is that we got very good performance of all reagents tested. I think we are very satisfied with the specificity, the reproducibility. Unfortunately, you see that we had inconsistent calibration with the INKIT standards, I should remind you that the calibrators within the different assays are made of plasmids, so it's synthetic standards. It's not made of true materials. We noticed an important variability of results, especially on clinical specimens, and this is not new. I mean, there have been many publications describing this variability, and it seems that the actual international unit reference material is not sufficient to standardize methods. I think recalibration against standards show that there is less variability, but it does not solve completely the problem of commutability. So in practice, this is actually the recommendation from the international guidelines. I think we need to follow a patient in the same laboratory, or at least in 2 laboratories that use exactly the same techniques. I don't think it's a good idea to determine a commutability factor because each patient is different, each specimen should be his own control. So how can we explain all these differences? Basically, as I've shown you at the beginning, we can clearly see that there is an heterogeneity of circulating free CMV DNA. And this is a study that was performed by Pedu and collaborators. And what they did, they looked at in 7 transplanted patients, and they look at the size of the CMV DNA circulating as a circulating free DNA. And what you see on this graph is that CMV fragment size was a little bit shorter than human fragment size with a median length of 149 base pair. And this is seen on all 7 transplanted patients. So basically what is circulating as CMV DNA in the circulation is short fragment of less 149 base pair. Now, if you look at the performance of PCR on these different fragments, you clearly see, and there are many publications showing that, but I've chosen the one from Leuzinger and Hirsch. They clearly show that if you quantify CMV DNA, if you have a short amplicons, it performs better. You see that you quantify more CMV DNA if you have a shorter amplicons, and that makes sense because you have more, you are going to quantify more of these small fragments that are here if you have shorter fragments. And that's very interesting. So at the end, when we consider all the platforms that we have evaluated in this study, we have a multiple step process that is a source of high analytical heterogeneity. First of all, I think maybe in the different clinical situations, we don't have the same CMV DNA circulating in the blood, on plasma, on urine, etc. We have to consider also pre-analytical conditions. We know that it may influence the fragmentation of DNA. And therefore, you have all this circulating DNA that you want to measure. Then you have to consider the extraction process. And today, it's very difficult to know if your extraction process is going to amplify or extract better small fragments rather than longer fragments. So we have unequal purification of different fragment lengths, and depending on the technique you use, you may promote the extraction of one over another. Then you have the amplification, and you've seen on the slide just before that the shorter fragment you amplify, the higher load you will obtain, obviously, because you are going to quantify all different fragments. So my last slide. So we've seen that the definition of an international unit has not led to an improved commutability of results, but you will hear a little bit more about that with Dr. Fryer just after me. I think assay manufacturers should communicate about the amplified genes, the amplicon size. I think we should not fight to get this information. I think it should be provided by all manufacturers. It's important for us to understand what's going on in our different laboratories. We need more data on the different circulating forms of CMV. I think we are missing a lot of information about that. And maybe we should think about new markers, and I'm thinking about the CMV anemia. There is going to be there are some publications now looking at that. Unfortunately, today, there is no standard for that, so maybe we will have to perform another study looking at that, but it might be interesting to follow patients with this new marker. And finally, I would like to thank my colleagues from different centers in France, the specimen preparation, and of course, our industrial partner with Bio-Rad. And thank you for your attention.
Thank you, Dr. Thibault. Our final presentation today is by Dr. Jacqueline Fryer. She is Principal Scientist at the UK Medicines and Healthcare Products Regulatory Agency Science Campus. This is formerly the NIBSC. At the MHRA, Dr. Fryer is a team lead for the development of reference materials for molecular diagnostics. The team maintains a portfolio of reference materials, including WHO international standards and WHO reference panels and NIBSC working reagents for the calibration and performance assessment of molecular tests for infectious diseases. Her talk will focus on if a redesigned WHO international standard for human CMV would resolve the communicability issue among nucleic acid amplification tests. Let's welcome Dr. Fryer.
Thank you for the introduction. And thanks to Bio-Rad for sponsoring my attendance here. So, as you heard, I work at the UK's Medicines and Healthcare Products Regulatory Agency Science Campus, formerly known as NIBSC. We produce NIBSC standards and WHO biological reference materials. We're also responsible for the independent batch release testing of biological medicines in the UK, and we perform research to underpin these activities. So WHO international standards are the highest order of reference material for biological materials. They're established following evaluation in worldwide collaborative studies and are assigned a potency in international units. Their primary purpose is to calibrate secondary references in terms of the international unit, thereby providing a uniform result reporting system and traceability of measurements independent of the method used. So proposals to establish international standards are initially presented to and endorsed by the WHO Expert Committee on Biological Standardization, and it typically takes approximately 2 years to source candidate materials and conduct the multi-center collaborative study to evaluate the suitability of the candidate. The report from this study is then presented back to the ECBS, who formally established the candidate as the international standard and assigned the concentration in international units. Replacement of a WHO international standard when stocks run out follows the same procedure, with the new candidate calibrated against the existing standard in the collaborative study to maintain continuity of the international unit. So the need for a common reference material to harmonize CMV viral load measurements was presented to a SOGAT group in 2007. SOGAT is an international forum that was established to discuss issues relating to the standardization of genome amplification techniques in infectious disease diagnostics. So the following year, a proposal for the first international standard for CMV for NAT was discussed with laboratory experts on CMV. Due to the challenge of sourcing sufficient clinical sample as a candidate material, it was decided that the source material should comprise the well-characterized clinical strain Merlin. It should be a whole virus preparation derived from cell culture, which could be extracted prior to PCR to harmonize the NAT assay, including the extraction step. It would be formulated in a universal buffer to allow for subsequent dilution in different matrices used for CMV monitoring. And this proposal was endorsed by the WHO ECBS in October 2008. So the candidate 09162 was produced the following year, and this comprised, as determined previously, clarified culture supernatant of Merlin virus, which was ultracentrifuged and then formulated in universal buffer before lyophilization. So the candidate was evaluated in a multi-center study alongside liquid preparations of the Merlin and 8169 strains, which were also prepared by in vitro culture and formulated in the universal buffer. And these were evaluated alongside a back-cloned Merlin DNA. So study participants diluted samples in the relevant assay matrix, so that was either plasma, whole blood, or urine, etc., apart from the Merlin back sample, which was not extracted but added directly to the PCR step. And the candidate 09162 was established by the ECBS in October 2010 as the first international standard, with an assigned potency of 5 × 10⁶ international units per mil. And this is intended to calibrate secondary reference materials for CMV NAT in international units per mil. So in the collaborative study, the utility of the candidate to harmonize measurements was demonstrated by expressing the individual laboratory results for each study sample relative to the results of the candidate 09162. So here, each box represents an individual laboratory result for, in this case, 8169 sample, with a spread of results in log copies per mil shown on the x-axis. For the 8169 sample that was included in the study, we saw a reduction in the variability of viral load measurements when the results were expressed relative to the Merlin candidate, with a reduction in the standard deviation of CMV measurements. So this suggested that the Merlin whole virus candidate could be used to harmonize measurements of whole virus preparations representing different CMV strains. The collaborative study also demonstrated that if CMV DNA is used as a reference material and is not included in the extraction step, there was no improvement in agreement between CMV measurement. So here, results of the whole virus Merlin candidate are expressed relative to the Merlin back purified DNA. And this was important to demonstrate because many reference materials included in CMV NAT tests comprise plasmid DNA, which is not extracted alongside the samples. So commutability is defined as the equivalence of the mathematical relationships among the samples of different measurement procedures for the reference material and representative samples. And this applies to all reference materials in the measurement chain, so from primary standard, secondary, tertiary reference materials, run controls, etc. This is important, commutability is important to ensure equivalence of patient test results independent of the method used. There can be a multitude of causes of non-commutability, which include both analyte and matrix-specific effects. A non-commutable reference material is unlikely to harmonize assay results for a given patient sample and may in some cases make the situation worse. Unfortunately, commutability of 09162 was not formally assessed prior to establishment, as it was not considered feasible to include a large number of clinical samples in the WHO study, and it was decided that it would be best assessed in separate studies. So commutability of the CMV international standard was first investigated post-establishment by Hayden and Prixatis et al. By testing pooled plasma samples from 40 CMV patients alongside dilutions of the international standard in 10 different qPCR assays, which were calibrated to the international standard. And as the figure on the right shows non-commutability was demonstrated with some assay systems. An interesting non-commutability was noted for assays with amplicon sizes greater than 100 base pairs. It's now clear that what is circulating in blood is not virus, but is almost exclusively free DNA that's highly fragmented. On the left, Tong et al. Showed by DNA's digestion followed by qPCR that of 103 archived plasma samples, 90% comprised exclusively free CMV DNA. And on the right, Pedu et al. Have shown the pattern of circulating free CMV DNA fragments in plasma of solid organ transplant recipients and shown that the median fragment length is 150 base pairs. So, as Professor Thibault shows, this extent of fragmentation explains why QNAT methods with smaller amplicons were previously shown to be more commutable than methods with larger amplicons. Subsequently, Hayden et al. Demonstrated that fragmentation of the international standard and a secondary calibrator improved commutability with CMV patient plasma. In this study, dilutions of the international standard were sheared by ultrasonication, producing an average fragment size of 166 base pairs. An assessment of fragmented WHO international standard alongside 42 CMV patient samples in 10 different CMV QNAT assays demonstrated improved commutability with fragmented reference material versus non-fragmented reference material. So in these correspondence analysis plots, clinical samples shown in blue, and dilutions of the international standard shown in red. So non-fragmented international standard dilutions on the left are distributed separately from the clinical samples, whereas fragmented international standard dilutions on the right are distributed amongst the clinical samples and are all inside the 95% prediction ellipse. So the international standard is used by manufacturers to define the sensitivity of CE-marked IVDs, and in the management of CMV and solid organ transplant patients, despite reporting in international units, guidelines recommend that viral load values are not directly compared across labs unless methodologies are comparable. And although harmonization of QNAT has improved, universal thresholds for therapy and treatment endpoints have not been established. So how can we improve this situation? So we issue approximately 250 vials of the international standard each year, and now stocks are likely to be exhausted in 3 years. It's clear that commutability needs to be addressed in the replacement of this reference material. We have had the opportunity to include CMV in a Euromet-funded COMET project, which aims to manufacture commutable calibrators and quality control materials for standardization and post-market surveillance of IVD tests. So this is coordinated by a consortium of European metrology institutes, clinical laboratories, and other organizations involved in standards development, including the MHRA. Within this project proposal, there are 2 tasks relevant to CMV. The first task is to understand the nature of CMV in clinical samples. So we plan to investigate CMV DNA in plasma versus whole blood from different transplant recipients, and hopefully also look at urine samples from congenital infections. We plan to use existing tools, including electrophoresis, sequencing, and to develop new novel protocols, such as digital PCR linkage assays, to investigate the nature and extent of fragmentation in the different clinical samples. Then the second task is to develop new candidate reference materials guided by the results of the first task. These are still likely to be derived from cell culture Merlin virus, as we can't source material from patient samples, but it would be fragmented to mimic CMV DNA in patient samples. The new candidates will be evaluated in a commutability study alongside the existing international standard to confirm their suitability for harmonizing CMV measurements. For practical reasons, the plan is only to investigate commutability with plasma from different transplant patients and to select QNAT assays based on those frequently used commercial tests that represent different formats, for example, long and short amplicons, different purification methods, and different sort of formats for the control materials provided in the kit. And we've performed some initial analysis of the most frequently used QNAT tests currently being used. So the pie chart represents CMV QNAT assays used by over 500 participants in 7 different EQA programs for quantitative CMV. There are a total of 40 different commercial tests being used. About an eighth of the tests are laboratory developed tests. So most participants are only using a handful of tests, and we're analysing the characteristics of the most frequently used tests in more detail. So an issue raised by reformulating the international standard will be how to maintain continuity of the international unit, and this will require careful selection of methods to calibrate the candidate against the existing international standard, and most likely will involve using digital PCR. Changing the formulation of the international standard is also likely to have implications for the QNAT tests which are calibrated against existing material, with tests requiring recalibration. There is also the potential that while reformulation improves commutability with patient plasma and other samples containing highly fragmented DNA, it may change or worsen for other clinical samples which might comprise more virion-associated virus. And finally, will it result in improved harmonization? Well, data from Hayden et al. Suggests yes, but we know that commutability is affected by a multitude of factors. So as commutability is a requirement for all reference materials in the calibration chain, it may still not be possible to achieve full harmonization of CMV measurements if commutable secondary and tertiary references are not available. So one of the initial tasks of the COMET project has been to develop a survey on CMV measurement to improve understanding of the application of QNAT to manage CMV in transplant patients, to guide the COMET project work focused on improving the commutability of reference materials, and to inform on the production of the second international standard. So this is a survey that's aimed at laboratory scientists and clinicians. So I'd like to invite you to take note of the survey link or scan the QR code and take part in this survey. I also wanted to announce the dates for the next SOGAT meeting, which will be taking place later this year. So as I previously mentioned, this is an international forum to discuss issues relevant to harmonization of molecular and serology tests used in the diagnosis and management of human infectious disease. And this meeting really supports the development of reference materials. Participants are from clinical labs, manufacturers, regulatory authorities, and the meeting will be taking place at the MHRA Science Campus, which is just north of London, and this will be a hybrid meeting, so it's possible to attend virtually. And commutability will be discussed at this meeting, as well as NGS and other ongoing standards development. And please feel free to email us for further information or request to be added to the mailing list for future events. And this slide just details the organisations contributing to the COMET project. So thank you for your attention.
Thank you, Dr. Fryer. I would invite our other speakers back up to the stage, and we will open this up to questions from the audience or our online participants as well. Please come forward to the microphones if you have questions and state your name and affiliation.
So while we're waiting please feel free to step up and ask questions. It's going to be a good time to entertain questions and kind of try to address the challenge that we face with this incredible variability of CMV assays. And I think one just kind of start the discussion for the group is one thing came to my mind just watching your three excellent talks was when you look for this recalibration, trying to standardize better, so things are pretty obvious, correct? We already know that different target genes, different amplicon sizes are always going to bring heterogeneity, correct? So I mean that's I think Dr. Gibault showed very well. So this is going to be an issue that it's going to be much more related to the logistics of the assays that we have in different places, and that's not gonna end, correct? So this is going to continue. But I think we have a room here to standardize, to minimize the variability in things that are not dependent on the amplicon size or the target genes. And I'll give a question because I think in my perspective as a clinician being at bedside, one of the things that is quite important to me is to try to understand if the patients, if the predominance, the predominant CMV that we are seeing, let's say, at the bedside, it's something related to reactivation or primary infection. Sometimes this is not that simple to distinguish because a lot of our patients have false positive serology, false negative serology. So I've had patients that clearly, just a few weeks ago, I had a patient that actually was I was communicated that the donor was negative serology, the recipient was negative serology, and about 2 weeks after the transplant, the patient had 1 million copies of CMV, in his plasma, and so there is no ways that serology was negative for the donor. We know that this is a primary CMV infection. So the question for you is there any ways that potentially part of this heterogeneity that we're seeing could be related to the different types of acquisition of that infection? So, primary infection versus reactivation versus reinfection. Is that possible that this could be somewhat leading to some of this assay variability?
Thank you for this question. It's not very easy to answer. Personally, I believe that you're right. I think during the different stage of infection, whether it's primary infections or reactivations, I'm not convinced that the virus circulates in the same manner. It might be it's CMV DNA, but it might be whole viruses or fragmented DNA. So I don't think there is an answer, but may miss something. But I think we don't really know what's going on during these different phases of the disease. So I don't really have the answer. But you raise a very important point. I think is the serological profile, the definition of the serological profile for the donor and the recipient. And you mentioned that there were false positive, false negative as well. And I agree with you that it's a real issue, and I don't know how to handle that. But I think it's a very interesting question actually. But unfortunately, I cannot help you. I think we still need to perform more studies to see what is the real viral forms during these different clinical stages.
Thank you. Questions from the audience?
I'm Cristina Olivo from Italy, and I have a question for Monsieur Thibault. I enjoyed very much the session, very interesting, your analysis. I'd like to know did you consider the way the conversion factor has been calculated from an experimental design of the experiment indeed, and the mathematical way? Because that can also be a variable.
Unfortunately, we have not done that because we asked the participant to give a result in international unit per mil. So I didn't get access to the calculation. But I can tell you that if you look at the CT values, we did exactly the same observation. So looking at the CT value, we obtain exactly the same kind of dispersion. And so I'm not sure it's due to a conversion factor between copies and international unit per mil. And basically because we got results in international unit per mil.
I have a question for Dr. Travi. Given that what we heard, there might be a new WHO-IS in 5 years, what are we to do in that case that you kind of mentioned where we have patients that come to your center and get one viral load test, and then they have to go back home, could be some distance, and have a different viral load test done? I mean, is there a way in this interim basis when we're waiting for new standards to use some sort of external control to help reduce that bias, that you can still use those viral loads, or is there just no way to really compare them?
So we have, in our center, we have to manage different solid organ transplants, and we have a particular characteristic. So some patients travel from the southern part of the country to our center to be transplanted. So they may fly back home, so we cannot ask them to check every time their blood test to our transplant center. So very soon after transplant, several weeks after, they have to go back. And actually, we needed to check again blood tests at the same lab, and we try to understand what to do with the local lab the patient is using. We ask them to do the CMV quantification by usually a lab that is located in a big hospital, but many of them are not transplant hospitals, and that doesn't mean that they have better assays than some specific local labs. So we just repeat the result, and we try to understand what to do, but it's very difficult. And for maribavir, we had to start a patient on maribavir after heart transplant, and the patient asked for personal reason to go back to home, and it has been very difficult to follow a viral load from a different lab. So it's something we really have to face with, and it's very difficult to manage those patients. But it's necessary because they have to travel back. Yes.
All right. Thank you.
And I think just, to continue this, the theme of resistance as well, I think that especially when we reach a point to have to use maribavir and so, or cidofovir for scarring, whatever drug you have available, I think that the reliability of the measurements become really critical because, these are the patients that potentially can end up with horrendous, infection that potentially can become incurable, correct? So, I mean, this is quite, it's quite a difficult situation. So that brings another question to mind is there any data looking into the discrepancy or the high heterogeneity related to, let's say, resistant CMV versus wild CMV? So is there something out there that can tell us? Because, I'll give an example. So I've had patients with relatively low, count with resistant strains, end organ disease, in which the lab would have, difficult to really look into the mutations because of the small amount, of DNA that they had available, even though the patient had severe disease and clearly, progressing to end organ disease from CMV. So is there anything that help us to understand if resistant strains would have different fragmentation or different heterogeneity compared to wild strains?
You're asking very good question. Again, I'm afraid I will not have a good answer. The only answer I think I can give is the fact that for most assays that we are running now, they are not targeting genes that are implicated in the resistant process. So basically, we are quite safe, and I'm talking under the control of my colleagues, but I think we are quite safe that we will not miss a resistance strain because we are not working on genes that are implicated in the resistance. But again, you're asking good questions, and I clearly don't know if a resistant strain would be differently fragmented than a non-resistant strain, for instance. So I think it's a question that is interesting to ask definitely, but I don't have the answer. But I wanted to make a comment about the previous question. I think now for CMV we have to think about not anymore about an absolute quantification, because each lab has its own absolute quantification, but we have to consider the patient as his own control. So basically you follow your patients. If the CMV viral load remains low, you are safe, but as soon as you increase, then you have to consider this increase according to where you perform the assay and with which assay you are performing the assay. So I think it's clearly a question of dynamics rather than an absolute quantification by itself. So because we are exactly in the same situation as Dr. Travis said. Basically, we are a transplanting center, and then the patient got transplanted in our center, but then it goes everywhere at least in the west part of France, and is going to be followed with other techniques.
Yeah, it kind of reminds me a bit of HIV viral load, where you might get a blip, but the guidelines say you need to monitor those 2 in a row to really tell if that's real or not. So it's probably getting to that point for CMV as well.
Yeah. For CMV, it's a little bit different because we've seen that with letermovir, for instance, you may have blips that do not correspond to true viral replication, but it's rather the consequence of the mode of action of letermovir in this patient. So it's a little bit different than HIV, but I agree with you.
Jerry from Forward Diagnostics, formerly from Exact Diagnostics. Great presentation. I did have a kind of like a question, like comment actually. I know there's all these presentations about the secondary standards, the international standard is that we got to prove commutability. But I think what we showed here is that there's actually a responsibility to the assay manufacturer that they need to show commutability needs to be a study done by everybody to prove that because I feel like we're trying to make secondary standards or international standards fit these assays, but these assays should actually be trying to prove that they are commutable so that they can say like, hey, if you move from another assay, this is really well done. If there's any assay manufacturers out there, I think that they had to share that responsibility. Even the lab has to share the responsibility. Like Dr. Tibble showed the commutability. It's a shared responsibility across standards, manufacturers, laboratories, and assay manufacturers. Just your thoughts on that.
Yeah, I agree with you. I think we should make manufacturers responsible a little bit, because when I saw how much it was difficult to get the information about the size of the implicants, I don't think this is normal. And I agree with you. I think this should prove us that they are well standardized against the international standard and everything. So I'm 100% with you, definitely.
Correct. I think it actually needs to look at more like the regulatory landscape, like IVDR, even and people have to submit to FDA submission, that commutability should be an aspect they're submitting to. That's what I'm thinking about.
Spain. I have a question for Dr. Freire, because I wonder how could you manage to get fragmentation in a standard in the standard material to mimicry the fragmentation in vivo in a patient. I was not sure about how could you manage that.
Okay, so Dr. Hayden et al., Jerry was part of that study, showed that fragmenting by sonication improved commutability. So that's the kind of approach that we're planning to do, but hopefully we will look at the fragment profile in the same way that Pedu et al. Looked at. So
yeah, because maybe you can, if you sonicate more or less, you can find a standard that is not a real CMV DNA that you can find in a patient. Well, for me, it's a big problem.
yeah, but it would be better than what we've got at the moment.
Yeah.
Yeah. I mean, the thing, commutability is affected by so many different factors. If we can get a step closer, then it's better than where we are. But yeah, improving the standard might not be the only thing.
More or less.
It is trial and error, yeah. I mean, we don't have this kind of situation for other standards that we have, not in the same way. Yeah, I don't think CMV DNA is the best marker, really, because we're not looking at current infection, are we? We're looking at something that happened in the past. So I did wonder how many labs might be using the CMV RNA assays or considering introducing those. That is only one assay at the moment, I know.
Mm-hmm. Thank you very much.
Any more questions? All right, with that, I think we can close the session. If anybody wants to come up and ask questions of our speakers, I'm sure they'll stick around. If you have any questions for us, definitely step by the Bio-Rad booth tomorrow, but enjoy your evening. Thank you. Thank you to our speakers.